And I think now we will shift to the last question, which is also one of the important questions here. We are in a short of time. Maybe after this question. Is there any concern for statin in CKD patients? I think this is a very important practical question because for a long of time we are using liberally all the statins without any concerns of the renal status. I'd like to ask some of the fresh faces, what do you do in your practice about using statins, those patients with CKD, about the dose of the statin, about the type of the statin?
شكرا دكتور سيد، شكرا دكتور. I prefer Rosuva, special Rosuva statin in a small dose with CKD.
What do you think, Professor Sameh, about those patients under dialysis? Do you think there's any concern for those patients for using statins under dialysis?
I think the problem is that whether these patients are using statins before starting dialysis or they develop the LDL, high LDL after dialysis. If they are on dialysis, they will continue. But starting statins after dialysis, I think is not preferred.
Dr. Ghada, Professor Ghada, what do you think? Is there any concern or liberally we can use any statin?
I should to ask my questions, 3 questions actually. The patient de novo for statin or not, as the Professor Sameh said. The second, the age of the patient and the risk of the patient. Is the patient in extreme risk, high risk, low or intermediate risk? Is the patient is old or young? If the patient is old and he's intermediate or low risk, I will not give. But if the patient is high risk, very high risk, I start to modify and I'll give. If the patient is before using, I'll continue. So I should to modify according to the age, according to the risk, according to the patient is novel for him this drug or he used before.
Professor Ayman, it's now your time. Dr. Yasser, do you like to add? Please, as fast as you can.
We should know that the cause of this in patient is atherosclerotic cardiovascular disease and not the CKD. So this is very important to reach the target of lipid profile in this patient, as the cause is not a CKD, but the heart disease. So this lipidemia should be treated in this patient. And we should differentiate between the dialyzed patient and the non-dialyzed patient, as we see from Dr. Ayman.
It's your time, Ayman, to give us the answer of this.
بسم الله الرحمن الرحيم. تحياتي دكتور سيد بيه، دكتور أشرف، شاكر على الدعوة الكريمة. أول مرة وإن شاء الله ما تبقاش آخر مرة في الإجابة. What do we mean by chronic kidney disease? It means structural functional problem in the kidney persists for more than 3 months and is classified according to the KDIGO classification and according to the cause, GFR, and category of albuminuria. And in the red and the orange lines, the stage 3 and stage 5 and 4 chronic kidney disease and patients on dialysis are at high and very high risk for cardiovascular disease. We all agree that it's a very high cardiovascular disease patients. The lower the LDL, the lower the eGFR, the higher the death and the higher the cardiovascular events in this New England Journal of Medicine study. Atherosclerosis also in this autopsy study showed that the lower eGFR, the higher or the more advanced atherosclerotic lesion seen in autopsy. Sudden cardiac death increase also with chronic kidney disease. The lower the eGFR, the higher the sudden cardiac death, with the higher sudden cardiac death in patients with dialysis. So these are the most dangerous people, patient on dialysis. And when I adjusted for clinical and angiographic variables, the lower eGFR less than 60 is an independent predictor of death and mortality. So chronic kidney disease is a pro-atherosclerotic state. Do statin work in these patients? As a proof of concept, fluvastatin in 2003 was conducted, shown that it reduced endothelial dysfunction, it reduced endothelin-1 concentration, reduced arterial stiffness in patients with hemodialysis, and the simvastatin reduce inflammation. So we all agree that statin should work in patients with chronic kidney disease. However, the answer is not that simple. It's not that simple. In 2005, we have this first study saying that atorvastatin is a 4D trial in New England Journal of Medicine. It said it's a randomized controlled trial, more than 1,000 patients, type 2 diabetes, on hemodialysis with hard endpoints. Atorvastatin reduced significantly the LDL, but the final Kaplan-Meier curve showed that no significant difference in the compared atorvastatin and placebo on the MACE in patients with chronic kidney disease on dialysis. So it doesn't work. Again, in 2009, in the New England Journal also, rosuvastatin on 2,000 patients or more on hemodialysis, it reduced LDL, reduced C-reactive protein, so it works. But on clinical background, it doesn't reduce this or MI in patients with chronic kidney disease on hemodialysis. What is happening? It's against our concern, our knowledge. Then we wait to 2011, Lancet, simvastatin and ezetimibe combination in up to 10,000 patients, 3,000 patients on dialysis, but they included patients with grade 4 chronic kidney disease. eGFR around 26, plus minus 12, with hard endpoint. Now we have good results. Now only we have good results. We have significant difference when we added statin to these patients with around 5 years follow-up. But when we dig deeper in subgroups, we found that patients with dialysis reach the unity line. So the patient on dialysis do not have improvement when they take statins, but the true improvement was in patients with chronic kidney impairment grade 4. Another meta-analysis in 2012, say, using different types of statin, atorva, prava, rosuvastatin, the final endpoint, so the final conclusion shows that there is 22% reduction in MACE in patients with chronic kidney disease with different types of statins, so we can use it. But when we dig more, we found that dialysis patients didn't improve. Again, another meta-analysis, dialysis patients didn't improve with statin. Again, we have what's called detrimental effect of statins on renal function. What is that? Detrimental effect of statin on renal function. The first signal was from the Planet 1 and Planet 2 trial. They are comparing atorvastatin and rosuvastatin high doses, and both reduce eGFR. However, they concluded that rosuvastatin was more harmful than atorvastatin. They concluded they are not powered enough to compare the two statins. But there is reduction in eGFR with the statin in these patients with type 2 diabetes with chronic kidney disease. Another trial on Asian population says that both atorva and rosuvastatin in high doses reduce eGFR, but rosuvastatin has more detrimental effect. There is a conflicting evidence. This is another trial on the same group of patients saying that no effect of rosuvastatin and atorvastatin on these kind of patients. The ESC said safety is the best. The goal is to reduce LDL safely, but in patients with eGFR less than 60, we have to reduce the dose. And the KDIGO guidelines put two limits of dose, rosuvastatin maximum 10, atorvastatin maximum 20, if the eGFR is less than 60. And the bottom line, statin do work in patients with chronic kidney disease up to 50 eGFR, but they are not effective in patients with on dialysis. In other words, dialysis modifies the effect of statins, modify the effects of statins. We don't know why. The explanation is bizarre now. Maybe it is too late. Patients are already dying from other things like sudden cardiac death, electrolyte disturbance, or atherosclerosis is not based in this kind of, on the dialysis patients on high cholesterol levels. So the final recommendation up to 2019, waiting for the new guidelines, not to initiate statins in patients with dialysis. If they are on statins, continue. And thank you very much.
Thank you, Professor Ayman. I think the answer is clear. We have to have nephrologists to us to categorize the level of the CKD, if it is CKD 3, CKD 4, CKD 5, to adjust the dose. There is some preference for atorvastatin. If we are on dialysis, we will continue statin. If you are not, we will not start. Thank you. The message is clear, and I think at the end of this fantastic session, I'd like to thank you all. This was IAVA all-in-one session. All of us share in this session. Thank you, dear panelists, and thank you all. And we will now shift to the coming session.